Everybody. So we're going to get started here on learning about eye disorders. I'm going to go through, your clinical judgment model and nursing interventions and some patient education you should be providing patients that have certain eye disorders. So if you could follow along with your student version PowerPoint, because here in mine, I do have some pictures I want to show you to help you visualize what a patient might look like with some of these eye disorders and what you might assess on them. Okay. Here are your learning objectives. You can read those on your own. This is covering eye disorders, peripheral neuropathy, and seizures. So any type of sensory abnormalities. Right here, we're going to focus on your introduction and anatomy. Okay, so any type of impairment in vision can affect both physical health and psychological health. Okay, so if anything goes wrong with your eyes, your whole sensory perception is off. It ranks one of the top 10 disabilities in the United States. Early detection and management can prevent and correct some vision and eye problems, but we need to educate patients if they end up getting diagnosed for a higher quality of life over time. Any type of UV light exposure increases your risk of cataracts and any type of eye diseases. Wearing sunglasses, avoiding tanning salons, but if they end up going, they need to wear eye covers. Occupational exposure. So if a patient works in an environment where they might have chemical exposures or any type of exposure where their eyes might be more prone to getting injuries, they should be wearing goggles. Same goes for us too, right? If we're having any type of exposure to patients' liquids or fluids, we should be wearing that eye coverage so we prevent any type of injury. And what's called OSHA, occupational, what does it stand for? Health Department helps manage the treatment for eye injuries on the job. Okay. We'll go ahead and go over the anatomy of the eye here briefly, right? So you have your cornea, which is right where you can see in the front of your eye. And I'm going to see if I can use my pointer here. Okay. So your cornea is right here. Okay. It's a transparent dome that covers the front of the eye and helps to focus incoming light. There is some fluid called aqueous humor that is behind the cornea. So it kind of helps lubricate the eye, and it fills that anterior and posterior chambers of the eye. We also have the iris, okay, that is behind the cornea, and the pupil, okay, that our middle black spot in our eye is called the pupil, okay, and certain meds, right, can dilate the pupil or make it bigger. So systemically, those meds can have an effect on your pupil reaction. And then the iris and the pupil control the amount of light entering the eye. The lens is located behind the iris, so this large area right here. Okay. And it helps change the shape and focus light onto the retina for clear vision at various distances. So it depends on how far away something is or how close something is. It's going to help focus the light. Okay. You also have the retina, which is in the back. Okay. All the way in the back here. So it's very light sensitive, and it converts light into electrical signals that sends it to the brain via the optic nerve, okay? So that nerve sends it all the way to the brain. saying, okay, what did I just see? What did I just process from that light entering? Okay. So the eye itself is a hollow organ and it must be kept in shape for vision to occur. So to maintain this shape, that fluid must be kept stable. This vitreous body fluid and the aqueous humor fluid. Okay. And they're set at present amounts to apply pressure inside the eye to keep it inflated. The pressure is called intraocular pressure, or IOP. And the IOP has to be precisely accurate within the eye to keep it stable. Okay. If the pressure is too low, the eyeball itself, okay, is too soft and it'll collapse, preventing light from getting in. If the pressure is too high, it'll collapse the capillaries in the eye and the nerve fibers. So back here, if pressure is too high with the fluid, it'll collapse all these capillaries and the patient won't be able to see. Okay. So just make sure you know your definition of the IOP. Okay. We'll move on to the next one. Some risk factors for all these eye disorders. Okay. Aging process as we get older, we have age-related changes in our eye, right? The muscle within our eye changes. We have vision-related changes. We have congenital risk factors, maybe something that we were born with. We have diabetes, which can be a factor in changes in vision if it's poorly controlled or not managed. That eye itself can have issues. Hereditary, if your mother or father had problems with vision early on, then you might be more prone to having issues. Medications, right? We just talked about your opioids or your benzos can cause pupillary changes. Trauma to the eye, risk factors for developing eye disorders later on. Okay. And I want to go back to the aging process here. There is a patient-centered care, older adult health on page 979 I want you to look at. So those structural changes occurred because of decreased eye muscle tone. The lower eyelid may relax. There's fatty deposits that may build up over time. Color perception changes. And in general, the intraocular pressure, or IOP, is slightly higher in older adults as we age. Okay? So keep that in mind. Your older adult patients may need more frequent vision screenings. And if your patient comes in and they don't have their glasses or contacts, we need someone to bring them in for them in order for them to be successful in the hospital and have a high quality of care. To be able to see what they're doing, we need them to have their accommodations. Okay? Our type of disorders that we're going to talk about here are cataracts, macular degeneration, and glaucoma. Okay? With cataracts, this has to do with the opacity or what we see through the lens. It distorts the image. So there's a lot of blurry or dim vision that the patient will report. The eye looks more cloudy And unfortunately, this can progress to blindness. It's usually diagnosed in your 50s, and the lens will thicken over time. For macular degeneration, there's more of a loss of central vision, okay? It's also known as age-related macular degeneration. So you may have heard of this. There's so many commercials out there about wet AMD or dry AMD, but it's the deterioration of the macula or the area of central vision, sorry, and can be age-related or exudative, wet or dry. So it can be related to age or just generalized issues with central vision. So they're going to have difficulty seeing straight on. Okay. And we'll talk about some clinical manifestations that they might report. Glaucoma is a group of eye disorders resulting in increased intraocular pressure. Okay. So anyone with glaucoma is going to have that increased eye pressure. If left untreated, it can result in a loss of sensory or peripheral vision. Okay. There's two different types. There is open angle glaucoma and angle closure. So open angle is the most common, or primary open angle. That's the most common. And angle closure, or primary angle closure, which is an emergency. That means there's too much increased eye pressure and they need to get to the hospital. Okay, and we'll go over kind of what they might manifest. Causes for cataracts, and we'll go back over this now. So causes for cataracts can include aging process, could be hereditary, can also be secondary to diabetes, UV light exposure, or medications. Macular degeneration can be age-related. Glaucoma can be also hereditary or age-related because, like I said, as we get older, our intraocular pressure does increase naturally. But if it's too high, it'll compress those blood vessels. So the patient won't be able to see because the photoreceptors in their nerve fibers aren't able to function normally. Primary open angle, which is the most common one, it's usually painless and it progresses over time. There's some gradual loss of visual fields, okay? Angle closure is an emergency and the intraocular pressure, the focus is decreasing that pressure, okay? Here's some pictures here. Which one do you think is cataracts? This one is cataracts, okay? The patient is going to complain of or report blurry or cloudy vision, and you can see a glare, okay? They might report poor night vision or double vision in one eye, but mostly blurry or cloudy, okay? This one, macular degeneration, okay? They have a loss of central vision, and you can see these fatty deposits building up. Because of that loss of central vision, so straight on, there's going to be difficulty in reading or recognizing faces. There's a distorted depth of vision, and they might have trouble seeing in low light or darkness. Okay, so maybe we should ask, have they had troubles with driving? That might be a good question to ask. Again, there's two types of macular degeneration. Dry AMD is the most common, okay? It's caused by these yellow deposits under the retina, and it progresses slowly over time. There is no cure, but it can be slowed with growth factor supplements. Okay. Wet AMD is way less common, but more severe. Okay. It's caused by abnormal blood vessels leaking into the fluid. There's a rapid onset and progression. So if you can remember dry versus wet and which one is more severe. Okay. Glaucoma, which is this one right here, is a gradual loss of side vision again. Okay. And it has to do with increased pressure, right? So there's going to be issues with loss of peripheral vision, halos around lights, and blurred or blind spots, right? So just think about all this pressure behind that retina is pressing on the cornea itself, and you can see a lot more redness in the eye for glaucoma because of all those blood vessels. Okay, and you see how that pupil is so dilated because of all the pressure. Okay, so please remember your distinct clinical manifestations. So cataracts is blurry or cloudy with or distorted vision. Macular degeneration is loss of central vision. Okay, and then glaucoma is loss of peripheral vision with halos. Okay. So what are some essential assessments for the patient that we need to ask? Okay. Specifically for cataracts, we want to ask about changes in vision. How is it impacting them today when they come in? Do they have an impact on any of their ADLs? Getting ready, making food, reading, writing, any of that. Tell me what you can see well and what you have difficulty seeing. Open-ended, because I want them to be able to express to me how they're feeling. For macular degeneration, what are the risk factors for this? How old is the patient? Over time, have they had gradual loss or has it happened suddenly? Are they having issues with driving, like I said? Or recognizing faces? Because with macular degeneration, it's more of a head-on vision loss with central vision. Okay, so a good question for macular degeneration would be, what challenges do you face when trying to read or see in dim light? Okay. Glaucoma, ask about sudden visual changes or any symptoms with pain around the eye, redness or swelling. Okay. So depending on their symptoms, it can drive your interventions and diagnosis for the provider. Okay, so these are the questions you should be asking relative to what you see. Okay, does the patient, what factors are we going to keep in mind? Does the patient wear glasses normally? Is this something new and has been getting worse over time? When's the last time they had a screening? Do they have a family history of vision issues? Okay. So some diagnostic tests that we might use for these patients are some specific tests such as the slit lamp exam, and that would be this one right here. Okay. That's a more common one for cataracts. The slit lamp exam helps test for anterior eye structures. The patient will lean their head on a chin rest to stabilize the head, and a beam of light is aimed. So the provider can locate the position of any abnormalities in the cornea, lens, or the vitreous humor, which is that fluid that's behind the cornea. Okay. Another test would be some retinal exams and tonometry, which is this one right here. What do you think the tonometry measures? It measures the intraocular pressure, which tells the provider how much pressure is being put on the eye, the outside of the eye. It measures the inside of the eye, so they put this machine on the outside and it tells you how much pressure is being pushed out. So the thickness of the cornea affects how much pressure must be applied. So this reading is actually indicated for all patients older than 40 years of age. Okay, so that's a very common one that they use. For macular degeneration, they might do a dilated eye exam. They'll put some drops in the patient's eyes and they'll see how dilated they get. They'll also do a fluorescent angiography function. So they'll inject some dye and then they will take a look to assess some leaking vessels within the eye. And then they might use this Amsler grid to assess disease progression. So with the Amsler grid, the patient would wear their usual glasses or contact lenses. They would hang the grid against a flat wall and then have the patient cover one eye at a time and focus directly at the center dot. So while focusing at that center dot, they want to know, does the patient see any wavy or distorted lines? If so, there may be some issues with vision abnormalities. Okay. For glaucoma, they would use the tonometry because why? Glaucoma has to do with increased ocular pressure. Okay, so we need to know how much pressure is being put on the eye. A usual reading is between 22 to 32. So anything above, a glaucoma reading is 22 to 32. So a normal reading would be 8 to 21. So anything above 30, I'm going to say is abnormal. Okay. So what's our priority problems for the patient that's being diagnosed with an eye disorder? If you can't see, what would be a priority for this patient? For all of them, it's going to be impaired visual sensory perception due to cataracts, macular degeneration, or glaucoma. And that's a safety issue. If the patient can't see what they're doing, they might be at risk for safety issues. So some solutions for patients diagnosed with an eye disorder. For cataracts specifically, I can't talk today. Surgery is the only approach to treat cataracts, and it should be performed as soon as possible. Okay. The most common one for cataracts is called a phaco or a phacoemulsification. It's a technique where they use some ultrasonic device to break up that cloudy lens, and they take out the remaining. They may put in an artificial intraocular lens to allow for faster recovery. They can also do a ECCE or extracapsular cataract extraction to remove larger, dense cataracts. The recovery is a bit longer for that one, so the phaco is more common. Okay. For macular degeneration for dry AMD, there is no cure, so the goal is to maximize the visual fields. Okay. Wet AMD, we may give supplemental growth factors or laser therapy when could be an option for either. For glaucoma, we may administer medications as prescribed to lower that intraocular pressure. So that is our ultimate goal, is to get that pressure down. There are several medications, which we'll go over in just a minute. If those medications are not effective, they may need some laser treatment or shunts to decrease the glaucoma. Medications. So mannitol and timolol are two of the meds that are in your module. So please make sure you review mannitol. You may have to look in your AI SurePath, but I'll tell you briefly. Mannitol is an osmotic diuretic. Okay, so that's your drug class. It's given to reduce intracranial pressure for treatment of cerebral edema and also to reduce intraocular pressure. So that's why we would give this to the patient, to reduce that IOP. So we want to make sure that we get the extra fluid out. Make sure you look up your contraindications. Since we know that it's a diuretic, what should we be monitoring? Electrolytes. Okay. So evaluating those electrolytes, renal function. Make sure we have the patient report any mental status changes. We monitor urine output, breathing. Most of the time, if the patient is getting mannitol, they will be in the ICU. They probably will not be on a med-surg unit because this is a high alert medication and it needs to be monitored very closely. Okay. So just know that we will be monitoring that urine output, the electrolytes, reporting signs of hypersensitivity like rash, dyspnea, itching. Okay. The other medication, timolol, is in your chapter. It is, let me see what, it's in a table. You can probably search it in AI SurePath also, but just make sure you know that it is a beta adrenergic blocker. So what would you need to be on alert for that? Okay. All right. So how are we going to take action with these patients to make sure that they are properly assessed and we make sure that moving forward, they manage their eye disorder effectively? So we want to make sure that we perform thorough assessments of visual changes, eye appearance, pain, asking them open-ended questions. Tell me more about your vision changes or loss. So there's no closed-ended questions. So we administer those medications accurately. That includes the eye drops. For the eye drops, I do want to go over the steps because you need to know how to give them properly and educate the patient properly. So always wash your hands before and after. Have the patient tilt the head back, pull down the lower eyelid, instill the drop without touching the dropper to the eye. Why? Because that's an infection control. Insert it in the corner of the eye, okay, which is the lacrimal canal, okay. After you're done inserting the eye drop, you need to use what's called punctual occlusion. Okay, so this is the lower punctum, and the arrow is pointing there. So you need to put a finger right there in this corner of the eye for 1 to 2 minutes to reduce systemic absorption. Okay, so I need you to know that, punctual occlusion. Wait at least your book says 5 to 10 minutes between different eye medications. So if you're giving 2 separate medications, you're going to need to wait. Okay. And then store the eye drops as directed. Okay. So make sure you're educating your patient on how to do those steps correctly. Okay. Something else is monitoring for complications. Okay. So are they feeling increased pain or swelling or redness? Or they're having worsening of vision? So when to report that? Providing support to the patient. Okay, so they've just gotten diagnosed with glaucoma or cataracts. So they need to understand their condition and their plan and coping strategies. Okay, so I've gotten diagnosed with this. So how am I going to live a good quality of life? Is there something that I need to change? Do I need to make things in bigger print? Do I need to add more lights to my house? Safety reasons, right? So making sure you're educating them on how to increase safe living environments. If they're not able to drive anymore because of vision changes, do they have arrangements for pickup or drop off to appointments? Things like that. Coordinating follow-up referrals to the ophthalmologist, scheduling screening follow-ups, and reinforcing those importance of regular eye exams. Explaining your procedures, instructing on NPOs if they're getting surgery, reviewing the medications, okay, that they should be taking, and they should take it as directed. Okay. If they're getting any type of surgery, they need to have someone transport them home, especially if they're going to be getting the phaco or the ECCE. They're going to need somebody to take them home. If they already have issues with vision, it's probably best to avoid any eye makeup, lotions, or creams. But especially on the day of surgery, they should not wear any of that. Instruct the patient to avoid rubbing the eye because rubbing the eye puts pressure on those nerve fibers. Avoid any heavy lifting, bending over, or straining. There is a box 39.6 that lists all activities that a patient should avoid to increase intraocular pressure. So make sure you read that. Also, box 39.9 lays out your patient education on living with impaired vision. So they need to come to follow-ups, they need to monitor healing. And I want you to emphasize that. If they have surgery, they may experience a dramatic improvement of vision within a day of surgery, but their best vision may not occur until 4 to 6 weeks after surgery. So it may take a little while to come completely back, and it may not come back all the way to what it was before. So just let them know it may take a bit. Wearing protective eyewear during any activities like sports, construction, anything that may involve splash to the eyes. Managing chronic conditions like diabetes or hypertension that can put extra pressure on the eyes. So they need to take their medications as prescribed. And then using proper lighting, as I said earlier, when performing any task to reduce eye strain. So we want to have them have a high quality of life, even though they may be diagnosed with these disorders. So these are your kind of overview. So for our outcomes, we want them to be stable and able to perform ADLs. We want them to adhere to medication regimens and proper administration techniques, follow-up care. We want them to have a reduction in symptoms like pain, redness, and visual disturbances, and confirm that the patient knows when and where to report new or worsening changes. So this is also your health promotion, chronic disease care, regenerative or restorative care, and then they also have vision rehab. So someone that may be diagnosed and this is a long-term thing, they may need to go to vision rehab to strengthen their eyes. Okay. This is also from your chapter. So you can take a look at that. Collaborating with the team, teaching to use eye drops correctly. Okay. Avoiding activities that increase intraocular pressure, heavy lifting, straining. Okay. Okay, let's do a check on learning real quick. The nurse is caring for a patient diagnosed with age-related macular degeneration. No specific type. Which of the following manifestations will the nurse expect to find with a patient diagnosed with AMD? Distorted vision, loss of peripheral vision, double vision, or increased sensitivity to light. Okay, I'm going to go on and we're going to look at the answer. Okay, the answer is distorted vision. So remember with AMD, we have distorted vision related to loss of central vision. So straight lines may look wavy. They also are going to have issues with vision in low light areas. So asking the patient if they're having issues recognizing faces or reading or driving at night will be highly focused on patients with this sort of disease. So make sure you take a look at those clinical manifestations. Loss of peripheral vision has to do with glaucoma. Double vision is cataracts, okay, with those halos because of the blurriness and the cloudiness, okay? We're going to move on to eye injuries, and then we will wrap up and do peripheral neuropathy.